Imagine if, on your 50th birthday, your body suddenly hired a microscopic demolition crew to just actively dismantle the physical scaffolding of your pelvic floor.
Oh, wow.
Right. It sounds like a premise for a body horror movie, but on a cellular level, that is quite literally what happens during menopause.
It really is. It's this profound biological shift. And, well, it happens quietly, often without anyone actually explaining the underlying mechanics to the person who's experiencing it.
Yeah, exactly. So welcome to the deep dive. Today we are exploring a highly requested, heavily stigmatized, and honestly fundamentally misunderstood topic, which is vaginal laxity.
Yes.
Specifically, we're tackling the burning question of whether local estrogen, so creams, ring, pessaries, can actually fix that really distressing feeling of looseness.
Right, which is such an important question for so many of you listening.
Definitely. And we have a brilliant stack of sources to guide us today. We're pulling from deep science pharmacological papers that map out cellular receptors, massive clinical meta-analyses, and highly practical guidelines from institutions like the Women's Health Clinic and the British Menopause Society.
It's a really crucial stack of research, I think, because it forces us to bridge this massive gap. We are taking the dense, molecular biology of hormones and applying it directly to everyday lived human experience.
Okay, let's unpack this, because if you look at the market right now, you see this endless sea of herbal pills, tightening wands, high-tech lasers. But before we can even ask if estrogen is the cure, we really have to figure out what the disease actually is.
Exactly. You have to define it first.
Right. And I always thought laxity was just a clinical diagnosis. Like, you go to the doctor, they examine you, and they say, yep, you have a grade 2 laxity.
Yeah.
But the sources say that's completely wrong.
It is entirely wrong, yeah. And honestly, that misconception is exactly where so much of the predatory marketing thrives.
Oh, I bet.
The most critical thing to grasp right out of the gate is that vaginal laxity is not an anatomical diagnosis that a doctor can just, measure with a ruler or an X-ray. It is fundamentally a patient-reported sensation.
A sensation. So it's subjective.
Absolutely. It is the physical feeling of looseness, a sense of reduced tone, or just a noticeable lack of friction and physical feedback during intimacy.
Wow, okay.
Now, to be clear, the distress it causes is incredibly real. But because it is a sensory experience, a doctor cannot look at a scan and objectively grade it like they would a broken bone.
That makes the diagnostic process sound incredibly murky.
Yeah.
Like, how does a doctor treat a feeling? And more importantly, how do we separate this from something like pelvic organ prolapse? Because when I hear pelvic floor issues, my mind immediately goes to prolapse.
Yeah, and they get tangled up in the same conversation constantly, but they are entirely different biological events. Prolapse, or a POP, is a structural physical descent of the pelvic organs.
Okay, so things actually falling down.
Right. That means the bladder, the uterus, or the rectum is dropping from its normal position and actively pushing against the vaginal walls. That is something a physician can objectively measure, they can see it, and they can grade it on a physical exam using standardized systems.
Okay, so prolapse is a structural failure, and laxity is a sensory failure.
Precisely. You can have severe laxity without any prolapse whatsoever. The organs are exactly where they should be, but the tissue itself feels loose.
Right.
And conversely, you can have a measurable prolapse pushing down into the vaginal canal without the patient feeling any sensation of looseness at all.
Okay, so if the organs haven't dropped, what is actually causing this feeling of looseness? Our sources point to two major life events that trigger this, right?
Yeah.
The first is childbirth, specifically vaginal delivery, and the second is menopause and natural aging.
Yes, those are the big two.
But these are two wildly different events. Childbirth stretches and can physically tear the pelvic floor muscles. Menopause, on the other hand, just drops your hormone levels. So are women confusing a torn muscle with a hormone deficiency?
That is the pivotal question of this entire topic, and the answer is a resounding yes.
Wait, really? Just a flat yes?
Yes, because to the brain, the sensation registers as the exact same thing, a lack of tightness and a loss of physical responsiveness. But the underlying biological mechanisms driving that sensation couldn't be more different.
Okay, break that down for me.
So childbirth is mechanical trauma to the muscular support hammock, right? The muscles themselves are injured. Menopause is a biological deprivation of a hormone that maintains the tissue's structural integrity.
Right, okay. So if childbirth breaks the muscle, that makes logical sense to me as to why things feel loose. But if menopause doesn't damage the muscle, How does a simple drop in estrogen create such a profound physical sensation of laxity?
To understand that, we have to zoom way, way in. We need to look at the microscopic level to see how estrogen acts as the master controller for the physical scaffolding of the vagina. And that brings us to the most abundant protein in the human body, which is collagen.
Collagen. The exact same stuff everyone is putting in their morning coffee to avoid wrinkles, right?
The very same. In the pelvic floor, collagen acts as the lytical scaffold. It provides firmness, structure, and resilience to the connective tissues in the vaginal walls.
Okay.
But collagen doesn't just spontaneously generate. Oestrogen is the primary biological signal that stimulates your body to actually produce it.
So oestrogen is essentially the project manager on a massive cellular construction site. It's constantly walking around telling the cellular builders to lay down fresh collagen and elastin to keep the walls firm.
That is a highly accurate way to look at it, actually. And when you hit menopause, that project manager retires.
Oh, no.
Yeah, estrogen production falls off a cliff, and collagen production plummets right along with it. The research shows that in the first 5 years of menopause alone, women can lose up to 30% of their skin collagen.
30%.
Yeah.
Just in the first 5 years.
Yes. And that catastrophic loss is happening directly within the vaginal walls, too.
But wait, if the project manager leaves, shouldn't the building just stay as it is? Like, it might not get any repairs, but why would it actively fall apart so quickly?
Because the body is a dynamic system. When the project manager leaves, the builders don't just stop working and everything freezes. That demolition crew you mentioned earlier takes over the site.
Ah, I thought you might say that. What exactly is this demolition crew?
They are enzymes known as matrix metalloproteinases, or MMPs.
What? That is a mouthful. What do they do?
Matrix metalloproteinases. Think of MMPs as the body's natural recycling crew. You actually need them, right? In a healthy body, they clear out old, damaged tissue so new tissue can be built.
Like taking out the trash.
Exactly. But they must be kept under strict control. In a healthy estrogen-rich environment, estrogen actively suppresses these enzymes, specifically MMP2 and MMP9.
So estrogen basically keeps the demolition crew locked in the trailer.
Exactly. But without estrogen there to suppress them, the activity of these degradative enzymes violently spikes. They just run rampant.
Wow. Okay.
They actively break down the collagen and elastin in the pelvic connective tissue much faster than it can ever be replaced. So you aren't just failing to build new structure, your body is actively eating away at the support beams that are already there.
That is terrifying.
What's fascinating here is how the cellular receptors completely dictate this process. Estrogen doesn't just, float around and magically build collagen. It has to bind to specific receptors in the tissue to give its orders. The sources outline two main types of nuclear receptors for this, ER-alpha and ER-beta.
Alpha and beta. Do they do different things?
Very different things. Think of ER-alpha as the gas pedal for cell growth and structural maintenance, and ER-beta as the brakes or the regulator. In healthy premenopausal tissue, these exist in a very specific, delicate balance.
Okay, so what happens to that balance during menopause when the pelvic floor starts failing?
Well, the sources cite a pharmacological study where the ER-alpha to ER-beta ratio was 10.8 in healthy tissue.
Okay, 10.8.
But in postmenopausal patients dealing with severe pelvic floor issues, that ratio skyrocketed to 29.6.
Wait, so it nearly tripled. But if ER-alpha is the gas pedal for growth, shouldn't a higher ratio mean more growth? Why is that a bad thing?
Because it represents a catastrophic misfiring of the tissue's internal communication system. The gas pedal is floorboarded, but the engine has no oil, meaning there's no estrogen to actually fuel the process.
Oh, I see.
The tissue literally loses its ability to process whatever tiny amount of the hormone are left in the body. This severe receptor imbalance, combined with the active demolition by those MMP enzymes, leads to profound thinning of the vaginal wall, severe dryness, and a complete loss of elasticity.
And this whole cascade of biological failure is what the clinical guidelines refer to as genitourinary syndrome of menopause, or GSM.
Exactly. The tissue just becomes incredibly fragile.
Okay, let me challenge you on something here, because this brings us to the core question of this deep dive. If this specific type of laxity is caused by declining estrogen allowing enzymes to get the collagen, does putting local estrogen back into the body actually tighten things up? Because I see these creams prescribed constantly, but frankly, it sounds like a glorified moisturizer. Can a topical cream actually reverse this level of structural damage?
To give you the direct answer, we have to draw a hard line based on the clinical guidelines. Local estrogen does not mechanically tighten the pelvic floor muscles.
Okay, hold on. If someone is listening to this and they've been using estrogen cream to try and fix laxity caused by a traumatic childbirth tear, you're saying it's completely useless.
For fixing the torn muscle, yes. If your sensation of laxity is strictly stemming from, because we have to go back to the definition of laxity, it is a feeling of looseness and lack of friction. If your laxity is driven by those menopausal tissue changes, if the mucosa is thinned out and the collagen scaffolding has been degraded, local estrogen is a biological powerhouse.
Okay, so it works on the tissue, not the muscle.
Right. It doesn't need to lift weights for your muscles because it fixes the tissue resting right on top of the muscles.
Ah, I see. So how does fixing the tissue cure the feeling of being loose?
It comes down to what we can call the grip factor. When local estrogen is applied, it drastically improves elasticity by promoting collagen cross-linking.
Cross-linking, like the rungs on a ladder.
Precisely. It builds those rungs back into the tissue, making it resilient and springy again. It restores the physical thickness of the mucosal lining, increases natural lubrication, and lowers the vaginal pH back to a healthy, acidic, infection-fighting level.
Wow, it does all that.
Yes. By restoring this thick, plump, responsive tissue, the normal friction and comfort return. The empty space is basically filled by healthy tissue again. Because of that, the subjective sensation of laxity is completely resolved for many women, even though the underlying muscle hasn't changed at all.
Here's where it gets really interesting, because I want to look at the actual data proving this isn't just a placebo effect, There's a massive meta-analysis in our stack of sources.
Oh, yes, the big one.
Yeah, it looked at 18 different randomized controlled trials involving over 4,700 women. They were comparing local estrogen directly against a placebo to see if it actually changed the biology of the vagina. And they used something called a maturation index.
Right.
What exactly are they measuring there? Are they literally swabbing the tissue and counting cells under a microscope?
Yeah, that is exactly what they're doing. A maturation index calculates the ratio of different types of cells in the vaginal wall. And what this massive study found was that local estrogen caused a statistically significant massive increase in mature superficial cells and a sharp, dramatic decrease in immature parabasal cells.
Okay, break that down for me. What is a parabasal cell and why do we want fewer of them?
Parabasal cells are deep, immature, highly fragile cells. In a healthy vaginal wall, they stay buried at the bottom. But when the tissue is starved of estrogen and thins out, these fragile cells become exposed.
Oh, so they're on the surface now.
Exactly. And they tear easily, they don't produce moisture, and they cause immense discomfort. Superficial cells, on the other hand, are the robust, tough, glycogen-rich cells that form the top layer of a healthy, youthful vaginal wall.
So by flipping that ratio, this meta-analysis proves that local estrogen isn't just acting as a temporary lubricant. It is literally rebuilding the vaginal wall on a cellular level, forcing the tissue to mature and act like a younger version of itself.
It is entirely reversing the biological clock for that specific mucosal tissue. It fires the demolition crew, hires back the builders, and replaces the fragile cells with robust armor.
Okay, but I have to play devil's advocate here.
Yeah.
If local estrogen is this miraculous cellular architect, why isn't it a magic bullet for all pelvic floor issues? Why do so many postmenopausal women still suffer from massive pelvic floor failure, even when using it?
That leads us straight into a concept highlighted in the advanced research known as the efficacy paradox. Yeah. It's a very frustrating reality in urogynecology, frankly.
What is the paradox?
Well, while local estrogen beautifully and reliably restores the microscopic tissue, making it highly effective for treating the sensation of laxity, and GSM long-term clinical studies show it does not always prevent the structural recurrence of severe pelvic organ prolapse.
Ah, so it fixes the drywall and repaints the walls, but it can't fix a cracked foundation.
That's the perfect way to visualize it. Prolapse involves the failure of major pelvic ligaments and deep fascial tissues. If a major ligament is mechanically stretched beyond its limit or physically torn from the bone, applying a hormone to the surface mucosa isn't going to magically reattach or shrink that macroscopic ligament.
That makes total sense.
Local estrogen drastically improves the tissue quality, which, by the way, surgeons love before they operate, but it cannot reverse severe structural anatomical failure. If we connect this to the bigger picture, we have to look at how this proven biological reality compares to the heavily marketed alternatives you see in clinics everywhere today.
You mean the lasers?
Yes.
Energy-based devices like the CO2 lasers or radiofrequency wands like Thermiva.
Yeah.
The marketing for these is absolutely everywhere. They claim they can tighten vaginal tissue and cure laxity by heating the tissue up to roughly 40 to 42 degrees Celsius.
Which is roughly 104 to 107 degrees Fahrenheit.
So they are basically cooking the tissue to intentionally trigger a burn or a mild injury response, with the theory that the body will rush in and stimulate new collagen to heal the burn.
Yeah, and this is where we really need to apply intense critical thinking and where the clinical guidelines become very stern. Yes, there are some small observational studies that suggest short-term benefits in tissue tightening and lubrication from these lasers. But these devices are operating in highly sensitive, often already compromised, estrogen-deprived tissue.
And the data we have for them isn't anywhere near that massive 18-trial meta-analysis we just talked about for oestrogen, right?
Not even close. The data for lasers is largely short-term and completely lacks rigorous, massive, placebo-controlled trials. Medical bodies still consider them highly investigational.
And it's not just a lack of data. There are actual safety red flags in our sources. The FDA in the United States has issued explicit safety warnings against using these energy devices for vaginal rejuvenation, citing severe reports of burns, permanent scarring, and chronic pain.
Right. And our sources note that the regulatory body in Australia went a step further. They recently reviewed the evidence and canceled approvals for these devices entirely.
Wow, just completely canceled.
Yes. They looked at the thermal burn risks and concluded that the dangers drastically outweigh any unproven short-term benefits. When you have a treatment like local estrogen, backed by decades of data, thousands of patients, and crystal clear cellular mechanisms, you really have to question why a provider would push an expensive, unproven thermal burn device.
That makes a lot of sense. If the tissue is already fragile and the demolition crew is already destroying the collagen, intentionally burning it seems, well, incredibly risky.
Exactly.
So let's lay out the practical, evidence-based takeaways based on what the medical consensus actually supports. If you are dealing with these symptoms, first, the guidelines emphasize that local estrogen is incredibly safe because it is applied directly to the vaginal tissue in very low doses. Whether by a cream, a tiny dissolvable tablet, or a flexible ring, it stays local. It doesn't flood your bloodstream.
Which is why the guidelines state it has very little to no associated breast cancer risk compared to systemic whole-body hormone replacement therapy. It is designed specifically for long-term maintenance. You don't just use it for a week to fix the issue and then stop, because the moment you stop, the demolition crew comes back.
But patience is required. The sources are very clear on the timeline here. While you might feel soothing relief from dryness almost immediately, it takes up to a full 3 months of consistent use for the estrogen to fully rebuild that cellular scaffolding, flip that maturation index, and entirely resolve the sensation of laxity.
Right, it takes time to build a sturdy building.
Oh, and there's one very specific, slightly amusing caveat mentioned in the clinical guidelines. If you're using a topical estrogen cream, you need to wait a few hours after applying it before having intercourse.
Yes, this is very important. The localized absorption of the mucosa is highly effective, but that cream will gladly absorb into any tissue it comes into contact with.
Any tissue.
Right. If you don't wait, you run a very real risk of literally transferring the female hormone directly onto and into your male partner. Timing is everything.
Definitely something to keep in mind. So what does this all mean? Let's bring it all together. If you are feeling a lack of tone or looseness, you first need to identify the culprit. If it's muscular weakness from childbirth, local estrogen is not your answer. You need to hit the gym for your pelvic floor with Kegels and physical therapy.
Right.
But if that sensation of laxity is driven by the tissue degradation of perimenopause or menopause, local estrogen is an absolute biological powerhouse. It fires the MMP demolition enzymes trying to destroy your collagen, it thickens the tissue, it restores the natural elasticity and grip, and it effectively eliminates the feeling of laxity for thousands of women, all without a single laser insight.
This raises an important question, though, a final thought experiment to consider as we look at the future of women's health. We now know definitively that local estrogen acts as a powerful preventative shield against tissue degradation by keeping those MMP demolition enzymes completely suppressed.
Right, it stops the wrecking ball before it even swings.
Exactly. So imagine a proactive shift in how medicine is practiced. If women were routinely prescribed a low-dose local estrogen at the very first, subtle signs of perimenopause, before the collagen scaffolding ever had a chance to break down and before the tissue ever became thin and fragile, could we entirely prevent the onset of menopausal tissue laxity?
That's a fascinating thought.
And if we could proactively protect that tissue from day one, could we make the entire multi-million-dollar industry of risky, unproven vaginal rejuvenation lasers completely obsolete.
Now, that is a massive paradigm shift. Moving from desperately trying to fix a collapsed building to simply maintaining the pristine scaffolding from the start, it really makes you look at that diagnostic X-ray machine differently. The picture of pelvic health might be murky at first glance, but once you understand the cellular mechanics, the solution is remarkably clear. Thank you for joining us on this deep dive. Keep learning, keep questioning the marketing, and we'll see you next time.